Welcome to our video coverage of Chapter 13 regarding psychological disorders. This chapter does include a lot of detailed information, so you want to really hone into those details as you read this material. As always, I recommend using the virtual lecture and the study guide. There's actually 3 pieces of the study guide for this chapter. I wanted to cover just the highlights. So here we have the introduction to the idea of abnormal behavior itself. So as you read through this material, be sure to pay attention to those 3 Ds of abnormal behavior: deviance, distress, and dysfunction. Remembering that deviance means that the behavior differs from our expectations, our societal expectations. So deviance may or may not be helpful. Deviant according to whom becomes the problem, where distress does become considerably more helpful in the sense that distress is from the individual's perspective, and it is often where we find that dividing line between normal and abnormal behavior, so that an individual who likes to clean would not be distressed by their cleaning behavior, but a person who has OCD and feels he must clean and cannot stop and is clearly disturbed and upset by the need to clean would be distressed. So it's often at that point of distress where we find the dividing line, again, between normal and abnormal behavior. Similarly, the criterion of dysfunction is tremendously helpful as we consider abnormal behavior, where dysfunction means the behavior or the symptoms interfere with the person's ability to function. So if you can't make it to your job, can't take care of your family because of your symptoms, for example, your need to clean, then that's dysfunction, and that's going to be very useful in determining whether or not a disorder is present. We also always consider the duration and severity of symptoms. So perhaps you have depression that is distressing and causing dysfunction, but if symptoms only last for a day, it wouldn't necessarily qualify you for any particular diagnosis. So there are several models of abnormal behavior, and those are going to reflect those perspectives that you may have studied in your intro psych class. The psychodynamic perspective, for example, Freud's perspective, would focus on the unconscious mind. The behavioral perspective would focus on overt behaviors that we can see and how we change rewards and consequences or associations. There's unconscious associations like, for example, Pavlov's dog, who would salivate when he saw the researcher that brought his food. Those associations, for example, would be classically conditioned and part of that behavioral perspective. The cognitive perspective is the idea that our thinking and mental processes are the cause of our symptoms. For example, depressive thoughts and ways of thinking correlate with depression rather strongly. The social-cultural perspective would consider the impact of society, societal roles, for example, gender roles, the impact of culture and acculturative stress, etc. So those are some of the perspectives, some of the models that are included in your text. There are others, but all of these would consider the diathesis stress model inherent to understanding of abnormal behavior. So here, diathesis is your inherited predisposition, your genetics, for example, plus stress in your environment, trauma in your life, stress in your life. These things together result in the disorder rather than either one alone. We can see that psychological disorders are prevalent, so that anywhere from 30 to 50% of people will experience or meet the criteria for a psychological disorder at some point in their lifetime, depending on what study you look at and what group is included, what time period, for example. So these are some of those contemporary models to which I was referring. Note also the biopsychosocial model, or now termed the multi-path model. The multi-path model in, for example, the abnormal psych text that I teach suggests, much like the diathesis stress model, that a psychological disorder doesn't result from just one thing. It's not because this one thing happened. It's multiple biological, psychological, social, and cultural events that can result in the manifestation of a disorder. So that's a really important one. Looking at some of the specific disorders, anxiety disorders are interesting because they always are going to involve biological or physiological symptoms. You can't have an anxious response without also having activation of your body's fight or flight symptoms, or system rather. So when we look at some of these disorders like panic, there's so much misunderstanding about this one. It's one of the ones that I get irritated about when people talk about it, because although I always have compassion for people who have any sort of psychological symptom, feeling really stressed out in a situation, even if it gets your heart racing and makes you feel terrible, if it's a certain situation that caused those symptoms, that's not panic. A panic attack comes out of the blue. So while it may seem that something in particular caused that symptom, it comes out of the blue, and people don't understand why they're having all of these intense physiological symptoms like crushing chest pain or choking, smothering sensations, tunnel vision, passing out. And then those symptoms tend to increase themselves. So you think, oh my gosh, my heart is pounding, I'm dying. That causes those symptoms to increase. All of it lasts about 10 minutes, usually peaking within 10 minutes and being resolved by 60 minutes completely. Most people think that the first time they're having a panic attack, they don't think, oh gosh, look at me having a panic attack. They think I'm having a heart attack. Or they don't know it's wrong and they go to the emergency room. I liken it to feeling as if you're standing on a train track about to be hit by a speeding train, but in fact there is no speeding train. This is the prevalence of various anxiety-related disorders. The others are covered in your book. Note that agoraphobia, people think it means not wanting to be around people. It literally does mean fear of the marketplace, but it's actually a fear of being anywhere from which escape would be difficult or impossible. We rarely, if ever, see it except as a complication of panic disorder. Generalized anxiety disorder is opposite to panic disorder in the sense that the anxiety is free-floating. It's with you all the time, not limited to one discrete period of time. So it's more common than agoraphobia, for example, but a generalized anxiety disorder means that you're on constant watch for something negative to happen. So you have those bodily symptoms, but they're going to be less discrete and intense, more of chronic muscle tension and insomnia, etc. Specific phobias, fear of a specific object or situation, like my fear of wasps and hornets and yellow jackets. I hate those things. Where social anxiety disorder used to be termed social phobia, and this involves fear of doing anything embarrassing or humiliating. And an interesting symptom of that is people won't want to eat in front of other people if they have that disorder. And then OCD, again, people often confuse as well with having to have everything just your way. And OCD is not, in fact, that, although you may also have those symptoms. OCD is the presence of obsessions and compulsions, where obsessions are recurrent intrusive thoughts and compulsions are behaviors you feel you must do in order to reduce the anxiety generated by the compulsions. So OCD is very debilitating and disturbing. It's not just having to have everything just your way. So dissociative disorders, there's a lot of misunderstanding about these as well. Dissociation is splitting your consciousness. That's normal and adaptive. For example, when you realize your eyes have been following the page, but you have no idea what you just read because you were thinking about something else, that's dissociation, normal and adaptive. In the dissociative disorders, that normal adaptive ability becomes exaggerated to an abnormal level. So either you split off a large part of your consciousness, as in a dissociative amnesia, or in dissociative identity disorder, you've fractured aspects of your personality so that you're dissociating large aspects of who you are and dissociating so often and so much that it interferes with your ability to function. Dissociative fugue is my favorite disorder, which involves sudden and unexpected travel to a new location and assumption of a new identity with no memory for your former life. You can see why it's my favorite. It's very rare. We could all be in a dissociative fugue right now. Sometimes it'll be for hours, days, years, maybe forever. When you come back to who you were before your dissociative fugue, you have no memory for your time in the fugue. So you can use this to excuse behavior that's uncharacteristic of yourself. It's poorly understood and poorly studied because it's pretty rare. So looking at somatic symptom disorders, conversion disorder is when you literally put your stress in your body. So, for example, soldiers who can no longer handle the stress of combat have developed symptoms that get them out of that situation, like blindness that's not explained by any biological factor. And once the stressful situation is over, their vision returns. And they're not as concerned about it as they would be if it was not a conversion symptom. And then illness anxiety disorder is very much like hypochondriasis, being a hypochondriac. Looking at some of these mood disorders, I want to point out a couple facts about these. First, please refer to the virtual lecture for the various types of mood disorders, remembering that bipolar 1 is very severe, and cyclothymia, or the least severe type of depression, may never be diagnosed, whereas bipolar 2 is kind of in the middle. The differences are critical, so please look through that. Similarly, with a major depressive disorder, you're having recurrent episodes of depression that interfere with your ability to function and last at least 2 weeks. Whereas with dysthymia, by definition, you continue to function, although symptoms may come and go for a period of 2 years. Suicide is a risk for all forms of depression. All threats and talk of suicide should be taken seriously. 947 HELP is the helpline, but I also recommend 741. Honestly, I believe 947 HELP was defunded. So 741 is the crisis text line. You can also call 911 for yourself or a friend with a specific plan and the means, or even if you just need help with suicidal thoughts, it's okay to call 911 when there's imminent threat. Always find out where a person physically is, so you can send help if you need to, if you're texting the person or talking on the phone, for example. There's other information about suicide. Be sure to check out those myths and facts, for example. And then we have the section about schizophrenia, often confused with multiple personality disorder, but definitely different from multiple personality disorder. Individuals with schizophrenia do not have multiple personalities, and individuals with dissociative identity disorder don't meet the criteria for schizophrenia. Schizophrenia tends to be less understood by individuals because it's not an exaggeration of something normal we all experience, like anxiety or depression. It's really a breakdown of everything the brain should do, for example, interpreting the environment correctly, formulating appropriate emotion and behavior, having appropriate cognitions. So symptoms often include delusions or false beliefs, and hallucinations or false perceptions. And then they can also include inappropriate or flat, missing, sort of muted emotion, inappropriate behavior, less speech. And there are 3 types of schizophrenia. The paranoid type. A person with paranoid schizophrenia is not necessarily paranoid. I know that's confusing. I didn't make up the names. But a person with paranoid schizophrenia has mostly positive symptoms, where positive symptoms are things added to the schizophrenic person. For example, bizarre beliefs and hallucinations are not present in a normal individual, but are present in a person with schizophrenia. Whereas negative symptoms involve things that should be there, but have been removed, like motivation to do things or speech. When those things are missing or diminished, those are negative symptoms, and they're harder to treat. So the paranoid schizophrenic or person with paranoid schizophrenia has mostly positive symptoms, whereas the catatonic schizophrenic individual also has considerable motor symptoms. They may not be catatonic in the traditional sense of motionless and non-responsive. They may be catatonic and wildly flailing their body about or holding bizarre positions for weeks or months until their limbs swell from the pressure. They may lose bowel and bladder control. It's a very severe and rare, somewhat controversial type of schizophrenia. And then the disorganized type just includes significant disorganization of speech, whereas a person with paranoid schizophrenia would have delusions and hallucinations. They would be more systematic and organized than those of the disorganized schizophrenic. And then we can call an individual's schizophrenic symptoms undifferentiated, meaning it seems to represent schizophrenia but doesn't fit into any type. Or residual, meaning you were actively schizophrenic for a period of 6 months or more, but now you're in a residual phase where symptoms are diminished or gone, but you still have some residual effects. For example, people tend to have lower intellectual or cognitive function following schizophrenic onset. So the personality disorders are disorders of personality where the person's personality is the problem. So they tend to have early onset through teenage years, for example, and tend to be difficult to treat. The person's cognitions and behavior are affected. The way they respond is affected. So, for example, this individual pictured is said to have antisocial personality disorder, where this is against society and society's rules. And antisocial personality disorder tends to involve psychopathy or lacking a conscience or remorse, and sociopathy, which is breaking rules and laws. So these are your serial criminals who violate the rights of others without a sense of remorse. So borderline personality disorder is also discussed in your text, and this is on the border of a mood and a personality disorder. characterized by unstable moods and relationships, a very unstable self-image. One minute you're fabulous and wonderful, the next minute you're the worst person who ever lived. And it can be a difficult disorder to live with. There's considerable distress and dysphoria associated with borderline personality disorder. So that's it for this chapter. Again, always look for those details in the virtual lecture, the text, and the study guide.